We have a ton of ground to cover, so here's our rapid-fire roadmap. We'll hit cystic neoplasms of the pancreas, pancreatic ductal adenocarcinoma, the marvel of the Whipple surgery, and finally, we'll wrap up with pancreatic endocrine tumors.
All right, Section 1, Cystic Neoplasms of the Pancreas. Let's kick things off with these structural anomalies.
Now, identifying the exact type of cyst you're dealing with is absolutely crucial. Take serous neoplasms. These usually pop up right in the head of the pancreas, mostly in older patients. If you look at a CT scan, they have this classic sunburst appearance right in the center because of calcification. The good news here, they're typically benign, and the tumor marker CEA, well, it stays perfectly normal. But contrast that with mucinous neoplasms. These are sneaky. They typically hide out in the body or the tail of the pancreas, often in premenopausal women, and they show a totally different eggshell calcification, along with spiked CEA levels. You've got to watch out for these, because mucinous cysts carry a very real malignant threat. They're premalignant, which means they almost always demand surgical resection. You can't just leave them in there.
So let's move to a super high-yield cystic neoplasm, the intraductal papillary mucinous neoplasm, or IPMN for short. Unlike the mucinous tumors we just talked about, IPMNs actually connect directly to the pancreatic duct. And the major clinical clue you're looking for here is called Ohashi's triad. Picture a gastroenterologist performing an ERCP. They're hunting for three very striking visual cues. First, a heavily dilated hepatopancreatic duct. Second, thick mucin literally oozing out of the ampulla. And third, a swollen, gaping opening that we actually call a fish mouth deformity. If you spot Ohashi's triad, boom, you've diagnosed an IPMN.
Moving right along to Section 2, Pancreatic ductal adenocarcinoma. These are the deadliest culprits.
When it comes to risk factors, the genetic and environmental stuff is deeply intertwined. Smoking, obesity, and diabetes form your baseline risks, but certain hereditary syndromes, they are massive red flags. Peutz-Jeghers syndrome, for example, can skyrocket a patient's risk of getting pancreatic cancer by an astonishing 100 times. Think about that for a second. On a molecular level, this cancer follows a really strict adenoma-carcinoma sequence. The KRAS gene mutation is usually the most common early trigger. It's basically the very first genetic hit. Then a p53 mutation comes along, acting as the fatal late hit, and that's what tips the cells over the edge into full-blown invasive carcinoma.
Now, when a patient with one of these tumors finally starts showing symptoms, they almost always present with obstructive jaundice. And that brings us to a fascinating medical concept, Courvoisier's law. In the clinic, this is your absolute golden rule. It states that if a patient comes in with obstructive jaundice and you can physically feel a palpable distended gallbladder, it is almost never due to gallstones. Why is that? Well, gallstones cause chronic inflammation over a long period of time, which basically leaves you with a shriveled, fibrotic gallbladder that just can't expand anymore. So, if you feel a palpable gallbladder alongside jaundice, it's a classic detective's clue pointing straight to a cancer blocking the distal bile duct.
We group the cancers blocking that duct into a family known as periampullary cancers. They're called that because they all occur within just 2 centimeters of the ampullary opening, and honestly, they require pretty similar treatment. Now, they all present with that progressive obstructive jaundice we just mentioned, but ampullary tumors, they have a totally unique, kind of terrifying mechanism. They are highly friable. So as the tumor grows, it blocks the duct, causing jaundice, right? But then pieces of the tumor literally slough off into the digestive tract. This temporarily relieves the blockage. So the patient's jaundice bizarrely waxes and wanes, while all that sloughed off, bleeding tissue travels down and produces dark, bloody stools, which we call melena.
Okay, Section 3, the Whipple surgery marvel. Let's talk about the master surgical solution here.
You can't just go in and start cutting into the pancreas. Before a surgeon even commits to this massive resection, they have to prove the tumor hasn't invaded the critical mesenteric vessels sitting right behind it. To do this safely, surgeons have to navigate what is colorfully known in the OR as the tunnel of love. Seriously, that's what it's called. It's this absolutely essential, completely avascular tissue plane right between the neck of the pancreas and the superior mesenteric artery and portal vein. If this plane is clear, if the vessels show the surgeon some love, so to speak, then the tumor is resectable. But if the tumor is aggressively encasing those vessels, there's no way you can proceed with surgery up front.
But let's say that tunnel is clear. Once you're in, the massive resection phase begins. The surgeon is effectively clearing out the entire diseased crossroad of the digestive tract. First, they'll either transect the stomach or preserve the pylorus to help produce postoperative dumping syndrome. Then, they take out the gallbladder, cut the common bile duct, and resect the entire head of the pancreas right along with the duodenum. I mean, you are literally lifting out the central transit hub of the gastrointestinal system. It's a massive undertaking.
After removing all that diseased tissue, you're basically left with 3 stumps: the bile duct, the pancreas, and the stomach. So how do we rebuild? Once the disease is out, surgeons meticulously reconstruct the tract by attaching everything to a loop of the jejunum. You do a hepatico-jejunostomy for the bile, a pancreatico-jejunostomy for the pancreatic enzymes, and a gastro-jejunostomy for the food. It's like replumbing the whole system. Now, definitely take note of this. That pancreatic connection is the most notorious site for postoperative leaks. If you see turbid, amylase-rich fluid showing up in the surgical drain around day 3, well, that anastomosis has failed, and it is hands down the most feared complication of the whole procedure.
But what happens if you open the patient up and that tunnel of love is actually compromised? If the disease is just too advanced for a Whipple, surgeons pivot immediately to a palliative strategy. The goal here is to expertly alleviate the patient's severe symptoms without actually removing the tumor. We call this a triple bypass. They perform a hepatico-jejunostomy to relieve that unbearable itching and jaundice, then a gastrojejunostomy to bypass the gastric outlet obstruction just so the patient can still eat, and finally, a jejuno-jejunostomy to route the whole shebang together. It's not going to cure the cancer, no, but it vastly improves the patient's remaining quality of life.
Finally, we've arrived at Section 4, Pancreatic Endocrine Tumors Explained. Let's shift away from exocrine structures and look at these fascinating hormone hijackers.
The most common pancreatic endocrine neoplasm you'll encounter is the insulinoma. These are usually benign tumors of the beta cells, but they constantly pump out insulin. And this leads us directly to Whipple's triad. Now, actually scratch that. It's a totally different Whipple than the surgery we just talked about, but it's just as important. Patients with insulinomas often present with massive weight gain. Why? Because they are constantly eating just to combat the severe hypoglycemic drops outlined in this triad. We're talking fasting hypoglycemia, blood glucose plummeting below 50 milligrams per deciliter, and then, almost like magic, a rapid resolution of their neurological symptoms the absolute second you give them glucose.
Let's see how this builds with some of the rarer hormone secretors. You've got the VIPoma, which secretes vasoactive intestinal peptide, causing extreme watery diarrhea and hypokalemia. Then there's the somatostatinoma from the delta cells. This one basically halts digestion, causing steatorrhea and gallstones. But the one you really need to pay special attention to is the glucagonoma, coming from the alpha cells. It presents with what we call the 4Ds, the most distinctive being this very specific necrolytic migratory rash on the skin. This rash is completely driven by a severe amino acid deficiency caused by the tumor. Honestly, simply infusing amino acids can make that awful rash vanish almost entirely. Next up in our case files is the gastronoma. This is a tumor that effectively forces the stomach to produce massive, relentless amounts of acid, leading directly to Zollinger-Ellison syndrome. When a patient shows up with multiple, recurrent peptic ulcers, especially in weird, atypical locations like the jejunum, surgeons sort of have to act like treasure hunters. The vast majority of these gastronomas hide strictly within the anatomical boundaries of what's called Pissarro's triangle, or the gastronoma triangle. The boundaries are highly specific. You're looking at the junction of the cystic and hepatic ducts, the junction of the second and third parts of the duodenum, and the head and neck of the pancreas. Basically, find the triangle, and you usually find the tumor.
Now keep in mind, not all endocrine tumors put on this massive hormonal fireworks display. Unlike the active hormone secretors we just covered, non-functional tumors fly completely silently under the radar. Because they don't secrete active hormones to warn the patient early on, they just grow silently in the background, usually presenting much later as a large, painful mass in the head of the pancreas. So how do you prove these are endocrine tumors and not just your standard pancreatic ductal cancer? They have to be biochemically unmasked. We do this by checking the blood and tissue for very specific neuroendocrine markers, specifically chromogranin A and synaptophysin.
We've seen how this one organ can harbor devastating cysts, massive ductal carcinomas, and completely silent endocrine tumors, often requiring extreme surgical reconstructions like the Whipple just to give a patient a fighting chance. As we wrap up this fast-paced explainer, I want to leave you pondering this final thought. In an organ so biologically adept at hiding its deadliest secrets deep within the abdomen, what will be the ultimate key to early detection in the future? Will next-generation biomarkers finally allow us to unmask these diseases before that critical tunnel of love is ever compromised? Thanks for exploring the science with us today.